Hello, thanks for joining our webinar today, Integrating ACEs Science in Pediatrics, Early Adopters Share Lessons from the Field. The webinar is co-sponsored by ACEs Connection and the California Campaign to Counter Childhood Adversity. We've organized this webinar because California is moving forward on universal ACEs screening of children. And in this webinar, you'll learn how practitioners change their clinics, what lessons they learned, what they wish they had done differently, what the results of the transition are, and what they're working on now. I'm Lori Udesky, a staff reporter with ACEs Connection and the manager of the site's ACEs in Pediatrics community. I'm grateful for the technical and behind-the-scenes assistance of my colleagues Morgan Vian and Ingrid Cochran. Next slide, please. ACEs Connection is an active social network of more than 37,000 members nationally and internationally that support communities to heal trauma and develop resilience. We invite you to join ACEs Connection. Next slide, please. 4CA is a coalition of dozens of groups in California which provide cross-sector expertise in countering childhood adversity. Let me go over some housekeeping. Our speakers will answer questions at the end of the webinar. As questions occur to you, click on the Q&A icon. It's at the bottom of your screen. You could write your question in there and submit it. The webinar is an hour long, and it's going to be recorded and available to registrants. And this will be a first in a series on this subject. Altogether, our three speakers have more than 15 years experience transforming practices to tackle toxic stress and ACEs in children. Next slide, please. Dr. Ariane Marie Mitchell is currently a faculty member at Loma Linda University. She has several years' experience in primary care pediatrics, and as a senior scientist with the Community Translational Institute, she focuses on translating the science of ACEs and health risks into preventive practices in primary care. Dr. Marie Mitchell.
Thank you, Lori. I think the first most important thing I want to say about screening for ACEs is that you have to know why you're doing it. If you could go to the next slide, please. For me, that why came very directly out of wanting to do a better job for my patients. My impression of well child care is that it's a one-size-fits-all approach. That is, we were doing the same procedures and giving the same advice, regardless of the differences in risk. And yet there clearly were differences in risk between the patients I was seeing, but I wasn't quite sure how to define those differences or what to do about it. That changed when I read the ACE study. It occurred to me that we could use information about ACEs to tailor well child care and enhance the ability of pediatricians to help children grow up healthy. Next slide. The next question was how, which is another key point I want to make. Asking parents to report about the experiences of their children during a real-world pediatric primary care visit is different than having adults self-report about their early experiences. It's also different from reporting about trauma as part of a behavioral health visit or part of a pediatric research study. Why? Quite simply because of social desirability bias, as well as a fear of mandated reporters. And in other words, parents don't want us to judge them, and they don't want us to take their kids away. When I spoke to pediatric colleagues who were handing out questions very similar to the wording on the adult ACE questionnaire, they were getting minimal reporting. When we interviewed parents about the questions we were considering, they told us that these were very important questions for us to know, but that other parents were not likely to answer all the questions truthfully. So our emphasis from the start was how to ask questions about ACEs such that we would get some reporting and yet knowing that we would never get 100% of truth. Next slide. I won't go into a full description of our QI project, but I will highlight another key detail of how, which is that ACEs screening has to fit into the clinical workflow. Next slide. When we first started screening, we used a separate questionnaire about adversity, but we got complaints from both our providers and patients. There was far too much paperwork to fill out at well-child visits, and adding another questionnaire was not helping. This is what led to the development of the whole child assessment. Basically, we got rid of all the different questionnaires and created one form that asked all the questions we needed to cover, including questions about adversity. So even though we were adding questions about ACEs, we ended up streamlining and simplifying our workload. This slide shows our current paper process. Next slide. That's good. When the child arrives for a well-child visit, the front desk hands out the whole child assessment to the parent if the child is 0 to 11 years old, and to the adolescent if the child is age 12 or older. When the patient is roomed, the MA checks to see if the paperwork is complete. And if it's not complete, just encourages the patient to complete it. Next slide. This is a general overview of provider workflow. Notice that the first step is to use the whole child assessment to collect the well-child history. So ACEs screening is integral to our workflow rather than an extra process or an extra step. Notice also that the next thing is determining whether ACEs are present or not. Our workflow is not contingent on a magic cutoff score. Rather, we collate information about the presence of an ACE with whether or not the ACE is a current concern and whether or not there are related symptoms. Questions about key symptoms are also included on the whole child assessment. Next slide. Of course, our providers are worried about the possibility that a safety threat may be uncovered during ACEs screening, and you may be worried about that too. You do have to make sure that your providers know what to do if a safety concern such as child abuse or domestic violence comes up. But this is definitely the less common scenario. Next slide. The other thing you have to be prepared for is the possibility that you will have to refer a family for community resources. Shown here is how we categorize the most common concerns that arise and the types of resources needed. While you can create and maintain your own internal list, we have found it helpful to create partnerships with Public Health, United Way, and First Five so that we have access to a list of resources that is continuously maintained by the community. Next slide. But by far, counseling is the greatest opportunity. ACEs are about broken relationships, but we can help the healing begin by letting both child and caregiver know that we will listen and we will care. No, we can't fix broken families in one well-child visit, but we can identify critical needs and provide critical advice. If we're lucky, they will trust us enough to come back, and then we can continue the conversation, and that follow-up conversation will be more relevant to the actual needs of the family because now we have information about ACEs for context. There's so much more to say about counseling, but I don't have time to say it today. Except I will add that in my opinion, this is where primary care training related to ACEs should focus, because this is where the greatest opportunity for impact lies. Among the lessons we've learned, next slide, The first is that the screening tool must be acceptable to families and staff. That means they have to be comfortable with the wording of the questions and the purpose of the screening. The workflow changes also have to be feasible and time efficient. All this matters if you want whatever tool you use to screen for ACEs to actually be utilized. Sure, you could implement a tool that providers and patients don't like, and it might be passed out, filled out, and filed. And then you could check ACEs screening off your to-do list. But I don't think that's what we want to do. If we want ACEs screening because we want to help children grow up healthy, then pediatric practices need to be able to choose what works for their clinic and patient population. Our second lesson that I'd like to share today is that we don't have to wait until adulthood to see the impact of ACEs. Our patients are telling us about adversity in their lives, and we have seen that those reports are associated with clinical outcomes, healthcare utilization, and biomarkers of toxic stress. On the one hand, that's kind of discouraging to see that ACEs can affect life trajectories so early. On the other hand, that means that we can implement and evaluate the impact of interventions to tip the scales and improve child health. A third lesson that we'd like to pass along is that pediatricians have the opportunity to prevent ACEs, not just identify ACEs. The whole child assessment includes questions about risk of ACEs, such as child maltreatment or risk of having a caregiver with a mental health problem. Those questions about risk lead to some of the best conversations about how to support that parent-child relationship and build resilience. Next slide. So, in response to the question about what we wish we had done differently, we started with screening for ACEs because that was the doorway that was open, the small step forward that was possible. Now we're broadening our efforts to becoming a trauma-informed organization. If I were starting over and I had an organization that was committed to awareness about trauma, I would start with training for all staff about trauma and resilience, and then add in screening for ACEs. Next slide. Key to becoming a trauma-informed organization is recognizing the need to shift from a biomedical model to a biopsychosocial model and learning how to do that. If we really want to change the outcomes for our patients, if we really want to reduce the prevalence and impact of trauma, then we need to commit to a transformation in how we deliver healthcare. And that transformation is much bigger than just screening for ACEs. If we stay stuck in a biomedical model, we may think of ACEs screening in the same way that we screen for, say, tuberculosis or other infectious diseases. We may pick a screening tool that easily gives us an ACE score and focus our workflow on a specific cutoff that triggers a referral to the nearest behavioral health specialist. But that kind of reductionistic approach completely misses the complexity of ACEs, as well as the opportunity to use information about ACEs and resilience to deliver primary care. Shown here are a couple of examples based upon real patients I've seen. Case 1 had an ACE score of 1, and case 2 had an ACE score of 6. If our workflow depended upon an ACE score cutoff of 3 or 4, we'd miss or misdirect resources. I will say that I am grateful to have done my work at Loma Linda University, even though we did not start off with the idea of becoming a trauma-informed organization. A central part of the mission of Loma Linda is to deliver whole person care. So incorporation of ACE screening fit well with the goal of treating the whole child. In terms of our QI project, we are evaluating referral rates and reviewing our adolescent questionnaires. We're also working on electronic implementation. For our research, we are evaluating our scoring method. As I mentioned, our clinical workflow does not focus on the ACE score, but we do think it is useful to have a measure of ACE exposure and ACE risk. We are also conducting pilot research on interventions for families with ACEs. And I forgot to say at the beginning, but just want to say now, thank you for including me in this webinar. It's been a pleasure.
Here we go. Okay. Dr. R.J. Gillespie is a pediatrician with the Children's Clinic in Portland, Oregon. He is studying parental ACE assessments in pediatric practice and the effects of parental ACEs on key child health outcomes. Dr. Gillespie.
Good morning, and thank you for giving me the opportunity to speak today. I'm going to talk fairly quickly about something that that is near and dear to my heart, and that is our practice's work on assessing parent ACEs and what we've learned through that process. So we go right to the next slide. First, a little bit about my practice. We are a network of 30 providers that are in 3 practice sites. So we are a private practice. We're not affiliated with an academic center. And we've been doing a lot of screening protocols since about 2008. That's when we implemented developmental screening, followed the following year by screening for maternal depression and autism, and then since then screening adolescents for depression and substance abuse. All that to say that we've done a lot of work in screening in general. And so plugging in a new workflow for assessing ACEs, we knew how the mechanics of screening was going to go. We hadn't at that point actually talked at all as a practice about doing any sort of screening for trauma, but one of my partners and I independently and through different avenues read the ACE study and decided that it was something that we needed to do something about. Next slide. Really, when we thought about the effects of ACEs and thought about the lifelong trajectory that is possible for people with ACEs, our biggest desire, I think, was to try to figure out how to prevent ACEs from happening in the first place. Obviously, that's a very heavy lift. And so my partner and I, when we were thinking about how we would do that, we turned our attention towards parent ACEs, knowing that there are some correlations between parents' ACEs and kids' eventual ACEs. Next slide. And our thought was that if we could identify parents who were at greatest risk and bring their trauma histories out of the closet, figure out how to support them in a way when they felt most challenged without making them feel like they were being judged, that potentially we would be able to create a new cycle of healthier parenting. Next. And if you think about it a little further, I don't personally have kids, but I'm told that it's stressful. There are times in a toddler's life that are probably more stressful than the usual. And some of those examples are going to be when the toddler is naturally going through tantrums, if an infant has colic, when you're struggling with toilet training, hitting and biting, some of these natural things that toddlers do. If a parent had experienced trauma, was that going to trigger their fight, flight, or freeze response? And can we prepare parents to respond in a different way so that they were able to be more supportive of their kids and recognize how their own histories might impact their responses to their child's behavior. Next slide. And thinking a little further, if a parent has experienced trauma, do they have good ideas about how to take care of themselves, how to identify when they need help, how to model appropriate conflict resolution, how to do discipline that's developmentally appropriate, or even in some cases, how to play with their child? Next slide. In other words, can we really teach parents and children to be more resilient? Next. what we started with was 8 providers who piloted screening. And at our 4-month visit, we give parents the ACE questionnaire, along with a questionnaire about resilience and a list of potential resources so that parents can tell us what they're most interested in getting in terms of support. We also wrote a cover letter that explained the rationale for the tool so that parents could understand why they were answering the questions. And within our electronic health record, we created a confidential field so that we could document the results, but those results wouldn't be printed into notes to offer some privacy and protection to the families once they've responded to our questions. Next slide. So just going through our big lessons, and I think that the first big lesson is that assessing ACEs in practice is really within the skill set of a primary care provider. And I think that's one of the things that most providers are a little bit afraid of, is that it's something that's actually out of their skill set. When we ask parents what they wanted, they want fairly simple things. The most common resources that they requested are parenting classes, support groups, and more information about trauma and its effects. If you look at the AAP's policy statement from 2012 on the role of the pediatrician in addressing toxic stress, that's really what they said we should be offering: positive parenting, training, and better anticipatory guidance and better developmental support. Some of the evidence-based interventions within primary care that have been identified by authors in the literature, Traub and Boynton-Jarrett in particular, said that actually educating parents and patients and families about trauma is an intervention by itself. We started this screening in 2013, and in my experience, I've needed to refer a parent to a mental health provider twice, so not very often. And I think that what you start to recognize with time is a lot of the resources that you need as a provider are not what we would expect. So they're a little bit outside the box. So mentoring programs, perhaps like Big Brother and Big Sister programs, clubs and activities that offer families connection. These are the kinds of things that we're doing. So they're not really medical referrals per se. Next slide. Our second big lesson is to start small but think big. I think that when it comes to implementing something fairly significant like assessments for ACEs, if you start with your entire practice, you're not going to succeed. So we started with a very small group of people who are really willing to get their feet wet. So 8 of our providers who are willing to test it out, see how it went, and then gain enough experience to be able to answer questions for the rest of the practice. That was one of our primary lessons. I've been doing quality improvement in my practice for quite a long time, I think about 13 years, and I know which providers in my practice are going to run into trouble with new workflows. And so rather than starting with people who I know are going to struggle, I start with the ones who are engaged and interested and then spread it from there. So you don't have to start with a huge implementation workflow, but really start with a small group of people who are most interested. Also remember that the staff members are affected by the assessment process, and so becoming a trauma-informed office means that you do have to pay attention not only to your providers, but also to front desk, nursing and MA staff, and other people who have a role in the assessment process. And certainly for other staff members, this may be a triggering thing, and so it's important to have that ongoing trauma-informed care training for staff, as Dr. Marie Mitchell mentioned. Next slide. Our next big lesson was really to keep your end goal in mind. And for me, I think the biggest lesson is that the purpose of ACE assessments is not to force a disclosure, but to create a culture change within practice. And so for me, the idea that my families can come to me with any concern and any problem that they're having is the end goal, that my office is a safe place for parents to address whatever issues they're having. I think too that assessment tools, when they're done well, really have a purpose in educating families about trauma. And so the tool itself is a launch point for a conversation about trauma and its importance. I think that we included the resilience part in our assessment tool because I do want people to know that ACEs are not destiny, and that's part of the conversation as well, that resilience is something that can be learned and improved upon and taught, and certainly modeled to parents and children. Next slide. Our next big lesson is that you really need to commit to discussing all of the assessment tools. When I started my work in developmental screening training through the Oregon Pediatrics Society a long time ago, I noticed that there were some people who would do an assessment tool and collect it, and at the end of the day when they're doing their charting, that's when they looked at the tool results. And I think that what that did is it created, first of all, it complicated the workflow because you would have to go back and contact the families that actually had a failed developmental screen. But I think when you're doing assessments for trauma, the message of silence can be harmful, and that may have impacts on the provider-patient relationship. If you don't respond to a disclosure of trauma, then the message to the disclosure is that the provider either doesn't think the story is important or that the survivor is not safe disclosing their story. And so I think even if you are having one of those kinds of days where it's not, you're not in a good space to talk about trauma, it's far more important to acknowledge it and to come back to a time where you'll have more time to discuss it. So for example, this is a very important story. I want to spend some time talking through this with you. Would you be willing to schedule a follow-up appointment? So that you're never ignoring the results of one of your screening tools. I think too that the disclosures for families is sometimes difficult, and so it's important to really thank the person for their honesty and their vulnerability, and that by itself will validate the importance of the story. Next slide. The final big lesson for me is really remembering the purpose of your assessment tool. Next slide. One of the things that we found right off the bat was that there was a clear correlation between parent ACEs and kids' developmental screening results by age 2. And you can see some of the data in this slide that with each subsequent ACEs, maternal ACEs in particular, that added an 18% risk of failing the developmental screen at age 2. The parents' ACEs, or the father's ACEs, excuse me, were a little more powerful, although we didn't have as many fathers that responded. But if you look at the last slide, for example, or the last line on that slide, for example, looking at gestational age, so kids who are premature and the mom had 2 or more ACEs, there is about a 1.7 times chance of failing the developmental screen. If the dad had 2 or more ACEs and the kid was born prematurely, then there was almost an 8 times more higher risk of failing the developmental screen. So again, parent ACEs really do make a difference for kids' development. On the next slide, you can see a little bit more detail about the specific domains. So we found with a single maternal ACE, kids were more likely to fail problem solving. With 2 maternal ACEs, kids were more likely to fail 3 of the 5 domains. And with 3 or more ACEs, kids were more likely to fail all 5 domains. I think part of the importance of this is that ACE assessments, in my opinion, are not something that you do in isolation, but really is in the context of all of the other screens that we do. So the ACE assessments for us help us to inform potentially why the developmental screen failure happens, but also helps us to understand barriers that families may have in terms of not only promoting their kids' development, but also in terms of completing referrals and getting into resources that might help that particular child. Next slide. So this is kind of summing up if we were to project out what happens with paternal ACE or parental ACEs. We think that with a maternal ACE score of 10, that about 75% of those kids would fail their developmental screen by 2. Next slide. Our information, or the data that we got around developmental screening was corroborated by a couple of studies. One looking at parent ACEs and kids' risk of development in a convenient sample in the emergency room. And what they found is that the more ACEs that a mom had, the more likely the kids were to have concerns on the PEDS developmental screen, particularly if the maternal ACEs were household substance abuse, mental health, or parental incarceration. This doesn't say what the pathway is, but certainly tells you that there's a risk based on the parents' ACEs. Next slide. Similarly, looking at a cohort of maternal child dyads and early home visitation programs, looking at the ASQ social emotional, that there was more likelihood of failing the ASQ-SE if there's a history of parental trauma. Next slide. Some other correlations that we found between parent ACEs, and this is not our research, but other research in the literature, that if a child has, if a parent has ACEs, the child is more likely to have problems on multiple different behavioral outcome measures. The behavior problems index, measures of hyperactivity, measures of emotional disturbances are all going to be higher. A little bit stronger from maternal ACEs than paternal ACEs, but still significant. And in the next study, on the next slide, looking at health outcomes in particular, that with each additional parent ACEs, there's an increased risk of overall health being poor, higher rates of asthma, increase in excessive media use and other poor parenting practices. The way the math works out on that is that if a parent has more than 6 ACEs, their child has 6.4 times the risk of having asthma. Next slide. Our most recent study looked at utilization patterns in parent ACEs, so that with each additional maternal ACEs, there's about a 12% increased risk of missing well visits in the first 2 years. We didn't find that a correlation with missing immunizations, but given that there's a risk of developmental delay, it's likely that those parents are not receiving the anticipatory guidance on developmental promotion from us, and they may be missing the on-time administration of some of those developmental screens, meaning a delay in referral to services. Next slide. So to sum that part up, if we know the major outcomes for our kids, that keeps us anchored to our purpose in terms of doing the assessments. So if we know that parent ACEs are correlated with failed developmental screens, more behavior problems, higher rates of asthma, higher rates of missed well visits, and poor parenting practices, then that tells us that doing assessments for ACEs can't just be a click the box kind of a response where we're just doing the ACEs to satisfy some sort of outside requirement, but really, again, to integrate that information into how we take care of everyday bread and butter pediatric problems. Next slide. What we're doing now in terms of our work in the children's clinic is we're trying to figure out how we take that information that we know about parent ACEs and developmental screens to try to prevent failed developmental screens in the first place. And part of that is in the way that we change our developmental promotion anticipatory guidance, so that if we know that there's a history of trauma, we're going to be spending more time on positive parenting practices, more time on developmental promotion and helping families identify ways to stimulate their kids' development. But we're also working with a psychologist on specific interventions in the first year on resilience and attachment and attunement to see if our process of teaching families about attachment attunement will help to prevent some of those failed developmental screens. Eventually, we want to see if these interventions also result in decreasing child ACEs. That's something that we haven't done as a practice yet. We were waiting for our Child Protective Services to move to a differential response before we started screening kids for ACEs. That's a long story, but eventually we want to get to that point too, where we're looking at the kids' experiences to see if we are actually making an impact. And I think that's my last slide. Yep, thank you.
Well, thank you so much, Dr. Gillespie. That was very informative. And now, Dr. Deirdre Bernard-Pearl is the Medical Director of the Santa Rosa Community Health Pediatric Campus and the Elsie Allen Teen Campus. She is also part of the core pediatrics faculty and the Santa Rosa Nurse Practitioner Residency Program. Dr. Bernard-Pearl.
Thank you so much, Lori, for the opportunity to be on this panel today. I have for years admired and learned so much from both Drs. Gillespie and Marie Mitchell. It's such an honor to be here with both of you. From the very start of introducing ACEs screening, we have worked as a team with our parent advisory group to develop our approach. So I also want to thank my team at Santa Rosa Community Health and our parent advisors and advocates. ACEs screening over the past 5 years at the pediatrics and teen campuses at Santa Rosa Community Health has brought amazing results in many ways. I'm going to now show you a short video clip of one of the families I work with that demonstrates how healing the doctor-patient relationship can be for a family with high ACEs. The speaker in the video is the mother of my patient, Jose. She has overcome substance use disorder, and she was able to get her children back after a long road with CPS and foster care. She comments here about how helpful it has been that her son has been able to open up to me at our visits. And then she describes her own healing. So let's go to the video clip.
She knows everything I know about my son. And I get that comfortable feeling. where I could actually tell her, not hold anything back or hide anything from her. I feel that she needs to know. She opens up something in my son that he's a whole different child around her. I mean, his feelings come out. He cries to her. You know what I mean? It's like, he's not like that with anybody else. Now I'm clean and sober. I quit smoking cigarettes. I don't drink. I volunteer. I drive my kids to schools. I get up early. I go to bed early. I cook dinners. It's totally different from where I was 7 years ago, living out of motel rooms, you know, being there physically but not mentally for my children. I'm really lucky and happy that we ended up where we ended up.
What I hope came through in the video is how screening for and addressing ACEs in a clinic setting can be very healing. I think of ACEs as a path to building trust, and trust as an essential ingredient for healing. Next slide, please. And next slide, please. I'm going to shift into some of the nuts and bolts of how we introduced ACE screening and some of the lessons that we've learned along the way. So when we decided to start ACEs screening here about 5 years ago, we planned a training for all of our staff on the science behind ACEs and also on the actual screening tool. We also brought it to our parent advisory group and asked them how we should administer the survey. The parents decided they wanted someone kind and caring to give them the paperwork and to explain that everyone fills out a survey. They wanted the survey to be done in the exam room, and they wanted someone they had a relationship with to go over the answers with them. Based on their feedback, here's the flyer we created. Next slide. The flyer says, in case you can't read it, we ask everyone, understanding your life events is part of giving you good care. And we created it in Spanish as well. We added a message to the top of the ACEs questionnaire. Next slide. It says, health and wellness can be affected by difficult life experiences. We want to help you if you answer yes to any of these questions. Please circle yes or no for yourself and for your child. It's okay not to answer any questions that seem too much for you. We promise to keep your answers confidential unless there is actual physical abuse or sexual abuse taking place. And for the staff training we organized, we thought it would be a great way to learn by having the experience of filling out the actual questionnaire. Next slide. In that training, we distributed the ACEs questionnaire and gave our staff a few minutes, and then something happened that we didn't expect. Pretty soon, some of the people in the room, our staff members, were becoming tearful. I waited until everyone had completed the full questionnaire, and by this point, I would say about half of the room was in tears. So we paused the training and took some time to talk about what that experience was like for them and how it brought up so many of their own trauma histories. There were many lessons from doing that training. Most importantly was that having staff take the questionnaire sensitized us to what we would soon be asking all of our patients to do. Next slide. It also brought up some issues related to workflow. When it came to working out the details of where the questionnaire would be given, it was clear to many of us that the parent panel was right. It should not be given in the busy waiting room setting because it's so sensitive and the information is so personal, but it should be given in the setting of a private exam room. So that was the first decision we made, and that is what we've continued to do. The second big lesson that we learned had to do with ACEs screening of our adolescent patients. After a short time of screening, we reviewed the results, and we were very surprised to see that all of the teen patients screened had no ACEs. It was all zeros, and that just seemed strange and probably not accurate. So we regrouped to think about why is this? And what are we doing wrong? The suggestion was actually made by one of our medical assistants that maybe the reason why we were getting zeros was that we were rooming the teens with their parents. And maybe the parents were looking over their shoulders and making the teens feel a little uncomfortable about full disclosure. So they were just saying no to everything. Next slide. So we thought, well, all right, let's see if that's right. We flipped the workflow. We changed it over to where we decided to room the teen patients alone without the parents first, and then bring the parents in later in the visit. The confidential screenings that way could be done with the teens alone. And so we tried it for a few weeks, and lo and behold, we started to find out what was really going on with our teens. And of course, more than half of them had ACEs. And we've continued to room teens alone first since then. Next slide. The third big learning that I want to share with you today has to do with the response to patients who have positive ACEs screens. As medical providers, what do we do? What do we say? Many of us, myself included, started doing this work thinking of the ACE screen just like any other screening test in terms of the medical model. And what I mean by that is that we've been trained to screen for a condition. If the screen is positive, then we offer an intervention, whether it's a referral, a medication, a solution of some kind for the patient. Next slide. What we found was that this approach doesn't apply so well to ACEs. Many people with positive ACEs either don't want any intervention, maybe they're not ready for something, or maybe they don't need anything. So it's been a very humbling process where we've learned to make a shift from the medical model of telling people with positive screens what to do to being much more humble and asking them what is it that they want or need. We offer services that are available and have helped other patients with these issues and challenges. And that's been a much more successful approach for us. What we've also found is that even when patients do not choose to pursue any interventions that we offer, like counseling or parenting classes, it has been our experience that the act of ACE screening and listening attentively and validating the patient's experience in and of itself can be healing and usually significantly deepens our relationship and trust, which ultimately we feel allows us to provide better care. Next slide. So to summarize, ACEs screening can be quite emotional, so best to give the questionnaire in a private setting. Number two, teens are more truthful when their parents are not looking over their shoulders, so try rooming teens alone to do the screening. Three, expand the medical model. Not every positive screen needs a referral. Try asking patients what they need. The fourth lesson was about working collaboratively with the entire team, including patients, medical assistants, medical providers, in developing and rolling out the ACEs screening protocol. And remembering to expect that just introducing the topic of ACEs screening can be an emotional trigger for many of us. Before we started this whole project, I thought that I knew my patients well. What I found out for a lot of families is that I've learned so much about their parents' histories and about them. It significantly deepened our relationships to find out about these traumas. Patients, I find, almost never refuse to answer the questions, and it's been our experience that people appreciate us asking, and it gets them thinking about health in a different way. Next slide. I thought I'd also talk just a little bit about taking care of our team, our medical providers and staff, in a trauma-informed way. We are a supportive group, and working as a team, helping each other out is very helpful. And I've also found that having regularly scheduled support groups has been also very helpful for us. This exercise I'm sharing here by Rachel Remen is a great opener for starting medical groups, focusing on what surprised me today, what touched me today, and what inspired me. It helps to lighten a group. Next slide. Lastly, I'd like to recommend two great books on the topic of ACEs and trauma. If you haven't already seen these, on the left, The Deepest Well by Dr. Burke Harris is excellent. And on the right, a book by Bessel van der Kolk called The Body Keeps the Score is incredibly helpful on understanding the mind-body effects when it comes to trauma and trauma treatment. Next slide. So thank you so much to ACEs Connection and the California Campaign to Counter Childhood Adversity.
Thanks so much for your talk, and thanks all of our speakers for speaking. And now I want to remind everybody that at the bottom of the screen is a Q&A icon, and you can write in your questions there. And please go ahead and do that. I also want to let people know that this is being recorded and people will be able to have access to it after the webinar. So as you all know, and I'm sure many of the people who are participating in the webinar are aware, California is rolling out a universal ACEs screening for children in its Medicaid program. And some of you covered this in your talks, but I'm just wondering if when you're thinking about this, what is the first thing that a practice needs to consider to move forward on universal ACEs screening? And anyone can jump in.
I think for me, when I think about implementing any screening or assessment workflow, I go through 4 basic questions. Why am I looking? What am I looking for? How do I find it? And what do I do once I found it? And I think with ACE assessments in particular, you have to spend a lot of time on that last question, what do I do when I find it? Not only in terms of what your clinical workflow is going to be, but also in terms of how you as a provider will respond to trauma and be available to the disclosures of trauma, right? So there's sort of the, what do I do practically when I find it, but like, oh my God, what am I gonna do when I find it, right? So in terms of taking care of yourself as well. And so to me, I think that the first thing you really need to do before you have a practice embark in these kinds of screenings is a really clear answer to the what am I going to do when I find it. There's been a lot of ethical editorials, I think, in the pediatric literature about why do you do a screening tool if you don't have something you're going to do with the results. And I think that to me is the main crux of this question is if you're going to do the assessments, to do it meaningfully, you have to have a good answer for what you're going to do when you find it. I think for me that it's not always what we expect. Like I said, sometimes that's connecting people with support groups or with parenting classes or resources or more education. But again, you have to have a clear answer to that question before you start the screening, in my opinion.
Dr. Gillespie, I like how you broke down the questions that you think about for screening, and I absolutely agree with the importance on the emphasis of your last question. I'll just say that I think the first question that you listed is really important as well, which is, why am I screening? That is, if the providers don't, I mean, a lot of providers, of course, may know about the literature on ACEs and know that it's important, but if they don't really get it in terms of how it matters to their ability to care well for their patients, then they're not going to be as effective. So I think that question is important too.
Okay, let's see. Here's a question that's come in from Carla. How might health plans work effectively to support provider ACEs screenings? And does anyone want to tackle that one?
I think that's a great question, and that's a complicated question to answer all at once. I happen to sit on the board of directors for one of our Medicaid coordinated care organizations here in Oregon, and I think that the effort that we've been trying to put out in terms of supporting providers around ACEs has not been so much with the screening, but making sure that the network of community supports are ready to receive the kids in a trauma-informed way. And so we've put together a kindergarten readiness network that includes a lot of our public health partners and a lot of our community partners, with part of the focus of that network figuring out how to be trauma-informed as a community. And so in that respect, our health plan is trying to be a convener for the community to really help make sure that the community is ready for this kind of work. I think that health plans do have the ability as well, through a lot of their quality improvement programs, to offer that kind of direct practice support in terms of the nuts and bolts of actually doing screening and how to support the providers in the workflow implementation. So those could be potential avenues. I always worry a little bit about health plans moving to reimbursing for ACE screening, because I don't want people to do ACE screening just to get the reimbursement. I want them to actually have a more meaningful process than that. So I'm not a huge fan of necessarily having these screens reimbursed right off the bat before the practices are ready to really do the work in a compassionate way. But I think in terms of being a convener and quality improvement support, those are certainly roles that health plans can take on. And certainly I'm willing to be contradicted on that part if people disagree with me.
I agree. I would add in, I think that another opportunity for health plans and fits their role in terms of maintaining quality of care is to offer training around ACEs. I think all three of us highlighted in our presentations the different layers. There's more than just the nuts and bolts of handing the tool out. There's the how you respond to that and the opportunities to connect with resources in the community. And there's just lots of layers, and providers often find time to get that training. So offering CME sponsoring programs for their providers is a logical fit to me.
Okay, we have several other questions that have come in. How can a solo pediatrician in private practice implement this in the office? And this comes from Harsha.
I think it's mostly a willingness to give it a try and see how it goes. In my practice, we never had any sort of grant support for this or any kind of outside funding to make this happen. It was just based on our own will. Certainly in our state, there are programs that will help to do the trauma-informed care training for the office. And so that would be the first thing that I would do. And I think our other panelists have talked about this as well in terms of really supporting the entire office. That would be the first step. And then from there, I think, nailing down what workflow makes the most sense for you in terms of how to start. I've always seen our parent ACE screening, for example, as one piece of a broader trauma-informed care training screening program, so that it's not just one or the other, but potentially multiple different ways that you're doing assessments and screening, but starting with one small way and then moving from there. But I would start with helping your practice to become trauma-informed as your first step.
So another question, this is from Aldina. How did you all determine whether to screen parents, children, or adolescents?
For us, when we started with parents, we had the intention in the beginning to eventually screen kids and screen adolescents. We were waiting for our Child Protective Services to implement what's referred to as differential response. And what that means is that the traditional response for Child Protective Services is a forensic, did abuse happen or not? And then if it did, then move that child into foster care. The differential response would say not only did abuse happen or not, but what was the root cause, and is there some lagging skill on the parent's part, some social need that they have, or some other reason for the abuse that we can help with, so that it didn't automatically result in a a separation of the child and parents, because I think that putting a kid into foster care is also traumatic. And so it sort of amplifies, I think, the trauma that some kids are having. And so for us, we were waiting for that to happen before we started screening kids, because we wanted to know that our Child Protective Services was going to be supportive and going to be an ally in this work. And that hasn't been finished yet. So that's why we started with parents, was because we were waiting for our Child Protective Services to get up to speed.
Okay, and this is a question that I think we've all seen in some form or other, and this comes from David. Before we figure out how to best assess how to screen for ACEs, shouldn't we establish scientifically which tool to use and that is actually effective in improving outcomes? Who wants to answer that one?
Yeah, I mean, that's another tough question. And that's one of the, I mean, there was just a review article in Pediatrics about social determinant screening tools in general, and how there aren't a lot of psychometric properties that have been studied in these tools yet. With the exception, I think that the PEARLS that's been developed by Center for Youth Wellness has been fairly well validated. That said, the interesting conundrum, I guess, in terms of improving outcomes is that when it comes to social determinant screening tools and whether or not you actually improved an outcome, either by looking at whether a particular service was received, but also looking to see, for example, if you've managed to improve development. I think that requires a kind of study that goes outside of a typical medical system, and so it's a little bit complicated to study some of those things. That said, the interventions that are known to be helpful, some of them are just education and training on resilience. And so I think that rather than look at specifically just the psychometric tool, properties of a tool, look at the culture change that it results in. Are the families having a stronger relationship? And some of that is the social desirability stuff that Dr. Marie Mitchell was referring to, in terms of, does this assessment process improve the relationship with the provider? Is it something that families are willing to talk to and then bring their questions to their provider? I think that if we wait until all that outcome stuff is done, we know that the effects are there. Waiting for the outcome studies sort of means that a generation of kids, again, potentially could be not helped in a way that's meaningful. So I feel some urgency on this, and I guess I caught some of that urgency from Dr. Burke-Harris. But so to me, I think that figuring it out as we go is legitimate. We know enough to move forward, in my opinion. But I mean,
chime in, I would say that there are a variety of different ways to screen for ACEs, and there's different degrees of evidence on the tools. And it depends on how many risk factors you're wanting to look at. There are a whole slew of social determinant tools that have been validated that screen for 1, 2 or more ACEs. When you look at tools that screen for all 10 ACEs, there's a more limited number. But I think it goes back to what I was saying earlier, which is that question about why do you screen for ACEs is really, really important. And I'm a researcher. I'm very much in favor of evidence-based medicine. But if you see screening for ACEs as important to doing and delivering good medical care, then it's not so much about showing the evidence that this preventive service has changed outcomes. That's really important. That's what research is about, and I definitely think we want to get there. But that doesn't delay me personally from the value of including it in my practice today without that evidence.
So we're just about out of time, but I just want to tell all the participants, I know a number of questions came in. I'm going to be preparing a blog post about this, and I will also send those questions out to our speakers and include the answers in that. Additionally, I want people to know that we are going to have a series of webinars on this subject, particularly because California is rolling this out, and there are so many different ways and layers of how to look at this question. So please stay tuned, go to ACEs Connection, and you will see that there. In addition, you can get the recorded video in about a week's time. And I want to thank our speakers very much for participating and look forward to continuing the conversation. Thanks very much.
Thank you all.
Thank you.
Thank you. Bye-bye.